Okay, well, good afternoon, everybody, and welcome. This is Stephanie Hall, and I'm with the ESRD NCC National Coordinating Center. I just want to thank you all for joining us today for our ESRD NCC Professional Educational Webinar. As you know, these events are being held in partnership with the Centers for Medicare and Medicaid Services. The series of events feature guest speakers from around the country sharing how they or their organizations they are with are coping with COVID-19. Before we get started, I wanted to let you know this call is being recorded and will be posted to the NCC COVID webpage within usually 3 business days or sooner. Next slide. So let's just talk a little bit about the agenda today. What's this call about? You're going to be hearing today from Kimberly Davis. She is the Director of the Home Therapies Operations in Rogosin Institute. She'll be speaking on home dialysis during COVID-19, lessons learned, and round 2. We do want to hear from you today, so during the presentation, we really encourage you to submit your questions for Kimberly through the Q&A or through the chat panels. We will have time at the end of the presentation to go through as many questions as we can. Next slide. So these are the bi-monthly calls that we have for professionals. They're on varying topics. We hear from different stakeholders and peers in the ESRD community who are adapting to COVID-19. They will be sharing examples and provide real-world strategies for facilities to use. Next slide. So let me go ahead and introduce our speaker. Ms. Kimberly Davis is presently the Director of Home Therapies for Rogosin Institute. She oversees the largest independent home dialysis program in New York, as well as one of the top 10 ranked programs in the United States. Her dialysis career over 25 years has been as a nurse, an administrator, and director has been her life's passion, as well as to provide innovation to directly impacting the lives of those in the ESRD community. While her passion is most felt in the area of home dialysis, she also has experience in all levels of nephrology care, as well as being an instructor for staff training in the local community colleges in New Jersey. She is also a member of the Home Alliance, as well as participates with the iPro Network 2 community serving on their education department. Kimberly, I'm going to turn over the presentation to you.
I appreciate that, Stephanie. I'm very honored today to present for the NCC call. And to all of you out there, thank you for your dedication, service, and getting through round number 1 of COVID-19. I am really astounded by the talent and innovation that I've heard from doctors and nurses and even patients during that time. So what I wanted to present today was something on the realm of nursing perspective during the first round of COVID-19 and lessons learned, and now we're in round 2. Next slide, please. So the objectives for today are to review risk data from the first COVID-19 experience, review population risk data in regard to racial disparities, share experiences in mitigating risks in an operational home program, and demonstrate best practices developed during COVID-19 pandemic. Next slide. So what was the state of access to home dialysis prior to the pandemic? According to the Network 2 report from iPro in 2019, there were 325 facilities and only 143 offered home dialysis. Of 44,580 total prevalent patients, 2,350 were on home dialysis. Of 8,007 incident patients, only 642 were home. In 2019, before the pandemic, only 3.3% of total patients were home. Next slide. Now, when the pandemic first started, we had to look at population risk, and early on, We looked at populations in our New York City area, and some of the earlier CDC information revealed something rather shocking. And it was that in the Black, African American, or non-Hispanic persons, or Hispanic or Latino persons, their risks for hospitalization were 4 times higher than some of the cases presented, along with their death rate or mortality rate being substantially higher. This caused great concern going into the pandemic. Next slide. So when we look at racial disparities and risks, in the network alone, the demographic was as follows. 17.7% of patients were African American, 29.1% were Hispanic Latino. That meant that 46.8% of patients in the network were in 2 of the highest risk categories for contracting COVID-19. Next slide, please. These were some of our compounding risks and challenges as I work in an urban area covering many boroughs of New York. Providing dialysis in an urban area also has additional exposure risks. Public transportation to go to medical appointments, including dialysis. Communal exposure in performing everyday needs, whether it be food shopping, going to the post office, things such as that. Access to testing early on was a challenge for a lot of patients to have availability of a test. And the patient's home environment and number of people in the home was of big concern, as a patient may live with more than one person, especially in New York, and what if a family member or someone they live with contracted COVID-19? Next slide. There were also risks for nurses to limit exposure to other healthcare providers. Many of the nurses were working along with physicians who had to go into the hospitals to do acute care. They were being exposed to COVID-19. On many calls during the first round of COVID, I had heard many physicians say that they were keeping themselves distant from the nurses because they were afraid to get their nurses or outpatients sick. What was the potential impact on staff traveling back and forth to work? Every day in the back of my mind, I would have conversations with my staff to keep them off of trains and buses at high commute times. We would alter work schedules. We would alter our routines for the day, because not only was I concerned about patients, I was very concerned about my staff. Another risk that we found and a challenge was also that one of our home sites was actually located on the campus of a hospital. So that gave people more exposure to traffic, basic traffic through other parts of the hospital, with a testing clinic being located on the same site and access to the main hospital campus. Next slide. So I like to call round one batter up. This was the point where our team got together and we're looking at the challenges that we were facing and how could we take on this challenge and be innovative. Our team had a firm commitment. Home is best, home is first. Everyone is a yes until there's a no. One of the things that we really believed during this time was that by getting patients out of the inpatient dialysis centers, that we might have a substantial impact on preventing them from getting COVID-19. We were looking at this increase in our home training as a prevention in limiting risk. Next slide. So who was Team Rogosin? As I was introduced earlier, the Rogosin Institute is the largest independent provider of home dialysis in New York, and we are actually number 9 in the country and in the top 10. The census at the beginning of the pandemic was 216. Our typical training rate is anywhere from 4 to 9 patients per month. And our staffing typically in our clinics is anywhere from 2 to 4 RNs per program. Next slide. Team successes. For our patients who are part of our team, less than 5% contracted COVID-19. Less than 10 patients expired, but what we realized was the highest number of patients that had this adverse event actually occurred between February and March of 2020. Increase in patient adoption of home dialysis increased to 35%. And actually our rate of information sessions and education nearly doubled. Increase in patient satisfaction through the expansion of telehealth, which I will talk about on another slide. And also for patients, a decreased anxiety and fear that they could do their own treatment at home and stay at home, shelter in place, and have less anxiety that they would have to leave the house and their concerns about contracting COVID-19. Next slide. Many milestones were achieved during this time. Not only were our physicians involved in innovative protocols, our nurses set goals in looking at, in particularly this one program, it was one of our peritoneal dialysis programs that early on during the pandemic, they looked at each other and they said, we're going to exceed 100 patients. Within the first 2 months of the pandemic, they met their goal. They achieved that goal, went on to exceed that goal, and now are looking at achieving a 200 patient goal in the next 6 months. Next slide. Prevention through access. Early observation demonstrated a benefit in performing home treatment. This is merely observational at this point, as though the data has not thoroughly been collected. And also, most recently during round 2, is not all practices are consistent with patients throughout the country where there are now hotspots and patients are having an increased level of COVID-19 infection. However, what we did very early on was we mostly associated it with the ability to have a stricter quarantine. In the beginning of the pandemic, we went to shelter in place. Despite what the news was saying, we prepared all of our patients that they were going to stay home and they were going to have stricter restrictions than what was being recommended to the public. The outcome during this point as well, with patients experiencing what they were seeing on the in-center side and hearing over the news, also led to more patients adopting home therapies, asking if it was right for them, attending more educational programs virtually, which resulted in 20% more patients for our program going home. Next slide, please. The expansion and use of telehealth was a tremendous blessing during this time. Our physicians readily employed it. The patients readily enjoyed it. And the nurses found opportunities to expand and find other uses outside clinic visits, wellness checks, pre-training, information sessions, and education. We also used it for preliminary home assessments when patients were going home, especially on home hemodialysis, as we wanted to get a bird's eye view of what the patient's home looked like before we sent the biomed out, who could potentially be exposed if they were going into the environment. We found more efficient ways to confirm and teach our patients, including self-administration of medications. There were many patients in our program that had never self-administered Epogen or Mircera or any of their medications before, and it was amazing to watch patients performing this virtually over a Zoom virtual meeting with the support of the nurse after being trained how to do the procedure. We also had patient empowerment events. These were events that were consisted of our own patients, we call them wellness ambassadors, who present information on modality training, support, looking at what was going on in their environments, in their communities, and reinforcing to patients that this was a good decision to make in choosing to do a home modality, regardless even if it was peritoneal dialysis, for home hemodialysis, and also transplant. Some patients did not realize, probably after around June or so, that even their transplant centers had reopened and were able to take them to see virtual visits, to go and finish their workups, and many of our patients ended up getting their transplants after the first 6 months of the pandemic, which was amazing. Next slide, please. Use of campus. This was something we got really creative with because our patients, as you can see on the map, live between many boroughs of New York. But our facilities are located near those boroughs of New York. Despite the home program not being their home base, what we offered to patients to keep them closer to home, less exposure to their environment, was we diverted training to other facilities that were closer to the patient's home. We utilized other locations for their monthly blood draws. We set up separate areas that were separate from the clinic where a patient could come in, sit down, have their blood work drawn, a quick look over if needed, and out the door they went. Supply pickup. Patients could, if they ran out of something, come to the nearest clinic, pick up whatever they needed, or we would drop it off for them. Clinic visits. Clinic visits, when we were using telehealth, also, you could go to the clinic nearest to you, have your clinic visit with your physician who may have been on another campus. And we also did things for routine testing, such as peritoneal dialysis clearance. Our goal was to minimize the distance that a patient needed to travel. We also, in regard to monthly blood draws, had patients who may have been too far from campus, however, utilized outside lab, and other facilities also may have used in-home lab draws. Unfortunately, when the first round of the pandemic came, I was too late to get a contract for in-home blood draw. However, the nurses performed more home visits in order to get the blood draws done, and patients actually really gave a very high mark for the monthly blood draws being able to be done at a facility closer to their home. Next slide, please. Further nurse risk mitigation. Patients in high-risk categories were sheltered in place with nurses deployed to the home for blood draws and other needs. Many of our high-risk patients were afraid to leave their homes, refused to leave their homes. So there was truly no other way than for us to bring what we needed and to go into the home. Another creative resource that we had to find were resources in apartment buildings used to assist in supply deliveries. Many of our patients live in apartment buildings, many floors, and especially on home hemodialysis, peritoneal dialysis may receive 45 to 60 boxes during a month or even a bi-monthly delivery, or when the patient first came home and got their first delivery. We would go to the property manager and ask if we could hang flyers. Many people were home from work within the building, which they had carts and they helped their neighbors. And many of the patients who were not able to get an outside door delivery now had the entire building helping them to move their home dialysis supplies from the lobby up to their apartment. Another resource we found were community resources to assist with food deliveries. Since people were not able to get food delivery at home from a supermarket, were fearful of going out shopping, we found several resources in the community that were actually delivering meals to patients, which kept them healthy, had them eating good food when resources were scarce. Use of telehealth decreased the frequency of clinic appointments. Our patients were being seen virtually twice in a quarter, once on a physical visit. At this point, we were able to provide them with the ability to not have to come to the clinic once a month until it was necessary, given that their blood work was drawn. This was a big benefit for patients, especially, as I said, we wanted to mitigate risks with them being on public transportation or in an Uber or traveling for some great distances to the clinic. Home deliveries of medications and supplies were done in place of a patient coming to the unit. We decreased extra visits. Many of you already use these resources for your patients already, but even if a patient needed something from the clinic that we were unable to drop off, we would send it out to them FedEx or UPS. Next slide. So what is the round 2 focus? Timing of clinic visits requires coordination if patients are seeing family, especially for the holidays, which was a new experience for us this time. Patients were asked if they were traveling. Patients were asked what their opinions were about wearing a mask. And if they were leaving the area, proper quarantining when they returned to come back. We continue to be more stringent on home patients than what is publicly recommended. Caution is better than contraction of COVID. We're screening our patients now for vaccine acceptance when available. That's been something you've been hearing about on the news, and we are asking patients what their opinions are about receiving that. We've monitored antibody levels in our patients for a perspective on patients that have contracted the illness, how long they retain their antibodies over a period of time, and remind them because they have antibodies does not mean you're immune. We follow the network recommendation to achieve 90% flu vaccine rates in all programs because we can't take our focus off of another illness that can affect our patients where we do have vaccine. Next slide. Improving access through community presence. We continue the network and encourage patients to use resources to empower patients and remain connected. Some of the resources I have listed you're very familiar with: Home Dialysis United, Home Dialysis Central Discussion Group, New York State Chronic Kidney Disease, CKD Champions, all connected with links. I have seen many, many patients, more so in the last year than I have seen in the last 3, discussing or encouraging other patients to start doing home dialysis, to do home dialysis, to calm the fears of COVID-19 and what this meant to them. There is much more communication occurring in the community. Next slide. So my closing thoughts. Nurses have an important role in not only empowering patients, but themselves. Being innovative will lead to the best outcomes for patients and impact the perception and delivery of home dialysis. Collectively sharing these innovations will ultimately lead to improving care for patients. Next slide. I would like to thank the NCC again, as well as all of you in attendance, for this opportunity to present to the group. If there are any questions that anyone has, please feel free to put it in the chat so that we can answer them.
Thank you, Kim. Thank you for sharing all that information. That is really inspiring, and I have to say thanks to you, your team at Rogosin, that you have had such a good success and been able to grow your home programs in a time during our pandemic. So that's a very good thing to hear and very positive. So, and like Kim said, if you do have questions for her, please submit them through the chat or the Q&A. We should have time to answer some questions. I do have some, Kim, we'll get to in just a moment. So, but again, thank you for all that information and sharing. So we appreciate a lot of good stuff happening, it sounds like.
If anyone else wants to share anything that positively happened to them as well, please do.
Exactly. We always hearing about so much about the positive COVID, so it's nice to hear some good things are happening out there. Very, very nice. So there is some questions. We'll go ahead and get started, and if there's more coming in through the chat, we'll try to get to as many as we can. Something I kind of had a question that toward the end, you talked about discussing with the patients about the vaccine. What has been the reaction of the patients when you have talked to them about potentially receiving the COVID vaccine?
Well, one is that, the patients are of the understanding as well that in the clinical trials that it was never tested on dialysis patients, which they are aware of. Two, I've had mostly mixed thoughts about receiving the vaccination. Some are, let's see how it goes with the other folks first, and they would consider later. Some patients also returning to the clinic, for the vaccine itself. I think I heard this morning as well that some retailers and also pharmacies will be carrying the vaccine. So, they might be able to get it closer to their home as well without a clinic visit. So I think that it's yet to come. But with patients who already refuse other vaccines, I feel that more education needs to be done for them as well, unless there's a medical exclusion.
Right. Okay. Well, that's good. Good to hear. Thank you. We do have a question, another question. Did you have any patients who started home dialysis during COVID and then wanted to return to the in-center dialysis? And then how did you address that scenario?
Absolutely not.
You had nobody that wanted to return in-center. Wow.
No fail option.
Wow.
With some patients, I think that when they express their concern about going into home dialysis during COVID, their anxiety over COVID may preclude their ability to be, of what they perceived about doing home dialysis. And then when they go to home dialysis, they might initially feel maybe overwhelmed in the beginning. With our patients, most of the patients that came during COVID that were from in-center wanted to get out. And I had a really great case study opportunity with a patient who had tested positive and remained positive for a long period of time outside of the usual window. And eventually we got him cleared by infectious disease. But in the interim, what I did with him was I did virtual education. So we were reviewing materials about home dialysis, understanding, what it's like. I was doing demos of the equipment from the training room with him just to keep him thinking more positively that eventually he'd get home, and he did.
Wow, that's wonderful.
Mm-hmm.
Great stories, great success. Mm-hmm. So the next one kind of feeds into that. How did you deal with patients that did not have like a laptop or iPad for your virtual training or your televisits?
Well, for televisits, we had very few. From what I observed, none that did not have a phone or an iPad or anything like that. Actually, for virtual training, that I did that with a patient via his phone. And so I have not encountered that yet, and I know that's a discussion about how you would provide someone with the even bandwidth is being discussed, you know, patients that don't have Wi-Fi and things like that. So I know that we've had a lot of discussion about that at the Home Alliance, but it was a pre-screener for me actually to have a patient do that. We did have a care partner of a patient who did not have access. Her husband had been hospitalized, and she came into the facility and did the care partner part of the training with the machine in like a mock treatment mode. So we were able to get over that barrier, you know, get through that one. But I think that's a very good question that a lot of us will have to figure out, you know, in the future.
Yeah, it's a learning curve for all of us still, I know. Okay, thanks. Here's a question. Is it going to be acceptable in meeting the CMS regulations to have done virtual PD clinic visits, especially given that we take care of pediatric population and a couple are quite far away?
For PD patients?
Pediatric.
Is it acceptable?
Yes.
I honestly, I don't have any pediatric programs, so I cannot answer that question. I'd have to find out how another facility is doing it.
Okay. And it says this question is about COVID testing for the home dialysis patients. Do they have to go on their own, or tests were brought into them?
They went on their own, or they were given access to a testing site that was near the hospital campus. But in order to start your home training, you had to be tested.
Okay. Okay, and we've got a lot of questions coming in here. When you virtually train, is that with equipment and live training?
Okay, so for virtual training right now, which is obviously not within the perspective of inclusive of training, it's a way to prepare your patient. We've used things such as the dummy tummy or the, I like aprons for peritoneal dialysis so that a patient can have a hands-on experience with transfer set and things like that. When I do, if we do home hemodialysis, the way I've done it was pretty much with the camera on the equipment, but it's demonstration at first, with the goal that when the patient comes in, that they've observed and now they're at the point where they can be at assist or try it independently.
Okay, great for that explanation. Let's see, another question here. It's what systems are you using for HHD and PD?
For PD, we use all of the available PD cyclers. And for HHD, we are using conventional equipment and also portable home hemodialysis equipment.
Okay. So you're not strictly training on one product? No,
yeah, because one is that the patient should really have an option of what fits best into their lifestyle. So if a patient desires travel over something else, and also dexterity, there's other things that play into that, but it should work for the patient, and the patient can choose which one they want.
Okay, great. Thank you for explaining. Good answer. Let's see. We've got a couple more coming in here, so you get to those. Okay, so
I see them scrolling.
So yeah, I know. I'm getting to them. Let's see. There you go. Okay. Do you find that when patients and family gets the virtual training, they come in more confident for the hands-on training?
Absolutely, because patient and family members actually are very nervous when they first start the training, and the more practice they've had, the less anxiety they have. I feel that there's more receptive learning going on even during the first few training visits, because they know what to expect, and they've also had a little bit of practice, which, other than, cannulation, they can achieve touching things and feeling more confident without, walking in the door the first day of training and being anxious.
All right. Well, thank you. Another question in here. Is there any push to move toward offering PD in nursing homes in the future?
We have we do have a PD program that is located within a skilled nursing facility in New York. Also, 2 facilities that do home hemodialysis. I believe that is something that is probably a presentation on itself, is dialysis in the nursing home environment. Mm-hmm. I believe that there is a push to do it. One of the things we saw with COVID was how debilitated people were after having the illness and requiring acute rehab after coming out of the hospital, and they may have been pre-existing home patients.
Okay. Okay, we have another question. So if you can answer, it says, how true is it that conventional dialysis machines, for example, the Braun and the Fresenius, generate more water and therefore will cost more to the patients? I was told that with next stage, the volume of water used is similar to just taking another shower, while the conventional machine is a lot more. Do you know the answer to?
The way I would answer that is the person who's asking the question, if you want to email me, and I'll give you the contact to reach out to next stage. If you need more information, I think that would, or to look at the website. But there is equipment, and there is developing equipment that uses a lot less water than an in-center machine.
Mm-hmm. Okay, good. Good, great, thank you. Question from a social worker. Do you find that patients are more adherent to the home treatment regimes in light of COVID?
Not necessarily. I found, patients that were doing virtual employment from home, the whole home environment has an impact on, working from home, your children being at home, and then having to do your dialysis. I think you have to closely monitor your patients during this time for depression triggers, and also that may lead to adherence issues. But for the most part, most of our patients are compliant. But I've heard a few that needed some additional support psychosocially because of the impact of the isolation and or not traveling and or working at home. So there could be more support there.
Okay, right. True, very true. Actually, for all of us. So this attendee says, I may have missed it, but exactly how is the virtual training completed? I heard mention of Zoom and such, but how is the patient getting that hands-on experience?
The patient is prepared to come in for the hands-on experience. Their full training is not done virtually. I need to make that clear because that is not approved by CMS. It is an education program using assisted devices that are not utilizing the patient's actual physical body to be connected to a machine. Like I said before that, we may use peritoneal dialysis training aprons or dummy tummy. And then the remainder of for home hemodialysis, there's booklets, there's videos, let's get together with myself or another nurse on a Zoom and let's have a discussion about this topic, and the patient has a copy of the book as well. So the final sign-offs are all done in the clinic, but we are not training patients all virtually.
Great, and thank you for that clarification.
Mm-hmm.
Good. Some more questions here. What have you seen a shift in the types of patients being referred to home dialysis since the pandemic?
Would it be patients that you wouldn't think have been referred to dialysis, sicker patients? Could they provide a little more information on that?
Yeah. Well, I think, it doesn't say, but you're right. I'm thinking maybe, we may not have thought of them as home patients before, or, they weren't interested. Are they now interested? Has there been any type that you have seen?
I think, you had two things going on at one time. You had the executive order that was released, and then you had the COVID-19 pandemic. So I think that added fuel to the fire where clinicians were probably saying, why not give it a try? Than saying, no, they're not a candidate for home dialysis. We give every patient a try. As long as they qualify to meet the criteria for the program, we'll bring them in. So I haven't, in my program, we have such a vast, difference in our population at times that, I've seen anything from sicker patients who can afford a staff assist to, patients who were AKI that went into ESRD to, it could vary, but, in an organization where everyone from the top to the bottom is supportive of home dialysis, every single patient is looked at and referred.
Great, wonderful. Well, and clearly to have your growth, the kind of growth that you could have had, especially during the pandemic, it's proven itself to be very true. So a question a little different, more around the hospitalizations of the patients. So what kind of transition of care has been going on from hospitals back to the home, from patients, home dialysis patients that have been in the hospital? How's that transition from hospital back to home environment been since COVID?
I have not seen many issues with transitioning someone back from hospital to home. I don't know if that's specific to the fact that they had COVID-19.
Right.
I know some patients, after hospitalization needed, they had in-home physical therapy that was provided. Some of them had in-home nurses. But like I mentioned before, we did not have that many patients that actually contracted the illness. Oh. So, at that point, other than, I think what people were more fearful of during that time is, should I go to the hospital because I might have broken my foot and I'll just stay home a few more days because I'm afraid of COVID. I think it was, we wanted to make sure that people weren't ignoring, their basic healthcare needs, that, don't ignore your diabetes or something more serious. Because you're fearful of going to the hospital because, there's COVID in the hospital.
Oh, look, and, congratulations to you. You did not have that many patients that had actually contracted COVID that you've had to then deal with this transition from hospitals back to, your facilities. That's great.
Yes.
Yeah. So a question that came in was what was the reaction with the caregivers with this format of training? And I think it came in, we were talking about the remote training, the virtual training. Were caregivers involved at any of those, and what was their reaction? Yeah,
so we did. We included caregivers in the virtual training. I think that, you have to understand that the patient, may understand more about end-stage renal disease than a care partner would. So it gives them the opportunity to actually get caught up, as I would say, to a level where they understand the language that you're speaking, which is the first thing, and then also not feel so fearful about a family member doing their own dialysis at home is the other that you see. We got some pushback about that. Family members, or a wife or a spouse doing dialysis on their spouse or family member. So sometimes when they go through the virtual training, I feel that they do better. Actually, I like that format a lot. We're trying to find ways to be innovative with the virtual training now and work with CMS. So in the future, I think there'll be something more substantial, with it, but we would like to do that.
Oh, great. Okay, good. So let's see. Looking into any more? If anybody else has any more questions for Kim, we're kind of winding toward the end of this presentation. So go ahead and submit them. And I'm going to kind of ask Kim something. Do you have any kind of words of wisdom or advice for family members or caregivers of someone who is considering home dialysis treatment option during this time of COVID?
Yeah, I would suggest that you get yourself connected either virtually or with the home training program to get a thorough education. I think that you should write down your concerns. I believe another aspect of this, especially for a care partner or a patient, would be receiving support or mentorship from a patient advocate or someone within your program to talk to them to answer any additional questions that they have. Right.
Yeah. It's and I think, you had maybe touched on it just a little bit earlier, but again, what tips or suggestions do you have for someone who might feel isolated by doing home dialysis now that it's during the pandemic?
Yeah. So we found through the pandemic, we actually have a holistic nurse on staff, and also one of our wellness ambassadors is a yoga instructor. So we started doing virtual yoga sessions with patients and virtual support groups within units, to have groups of patients attend things. We've also developed educational seminars for patients to join and talk about their concerns. So we're trying different things to bring us into the home or closer to them so they can feel more connected. But the holistic side of it with the yoga is something new that actually we see as being beneficial to the patients because then they're exercising as well.
Wow, that's a really a great idea. That's wonderful. So good idea. Another question just came in. How is COVID impacting the PD catheter placement and PD starts outside of the remote training?
Yeah, so in the beginning of the first round of the pandemic, the PD catheters were not considered an essential surgery. So we had many discussions on a higher level, and then finally that was one of the first waivers put in. But in the beginning, for about the first 3 months, patients were really having issues having PD catheters placed. After about June or so, I would say that those doors swung open, so our access centers and also our hospitals, returned to somewhat normal with PD catheter placement, but some patients had to be monitored and held off because of the fact that you could not get the procedures booked or time available.
Great, thank you so much. Any other questions? I'll get one more go around before I think we sort of look at toward wrapping it up. Or Kim, anything else you want to share for the attendees today? Any last
thoughts?
Yeah, closing thoughts.
Continue to be safe. Continue to wear your mask.
Yeah.
Continue to take care of yourselves. Everyone will get through this eventually.
Yeah. As we know, we're going into what I believe was predicted as the second phase. We're really going through another difficult time coming up. So it's still with us. Well, again, I always want to thank you so much for sharing your story, your successes. What a great job. Again, you and your team has done at Rogosin Institute. It's been a pleasure to have you today. If we get any questions in from our end, I will be glad to email them to Kim, but Kim has her email up there. If anybody does have any questions, you can feel free to reach out to you. Again, the slides are going to be posted to our NCC website within 3 days, along with the recording. So if anybody would like to look at the slides or listen to the recording, it will be available. Matt, if you could go to the next slide. Just a couple things before we wind up for today. We want to let you know we have some inspirational posters that are available to be downloaded and printed. They are focused on a few different topics. Some are on psychological or physical health. There's some on emergency preparedness and some on COVID-19. They are in PDF for on-demand printing, and you can see the website there. They're at our ESRDNCC.org website under professional, under inspirational posters. Please go check them out. Next slide, Matt. Also, just a reminder of our Kidney Hub. This is a mobile-friendly web tool created for patients, for patients. Again, it's continually getting new information added to it, resources, videos. You can see that there's information about home dialysis, about COVID, about transplant, always new resources being added. So please, pass this information on for your patients or for yourself. Next slide. And just as a reminder, as our next COVID-19 webinar events, our patient-focused one is next week, December 15th, 4 o'clock Eastern Time. And because of the holiday week, we are moving our provider-focused event to December 30th at 3 o'clock. That way, because it runs up, otherwise it runs up too close to the holiday. And again, you can visit the covidinfocenter.org to register. More information will be getting sent out on those upcoming, the professional provider event will be getting sent out here probably the end of this week. And next slide. So again, we just want to thank Kimberly Davis for joining us today for a wonderful presentation, for a lot of really good information and a lot of good tips. And there was been a lot of good questions came in for you, Kim. So thank you for answering all of those. We really appreciate that. And again, take care, everybody. Do enjoy your holidays. Be safe. And we hope to have you on our future webinar. Bye-bye.